Oh, guys, we're going to make a start. Okay. Okay. If everyone's have a seat, we'll get started because we've only got an hour. Great. Make yourselves comfortable. Cool. So, hello everyone. I'm Murray Ellender. I'm a GP in London and head of UK healthcare at Humour. We'll come on to what that is. And it's really good to welcome you all here today to this TechNExt session that's being hosted at Opencast, talking about making innovation happen in healthcare, because that's what presumably we're all trying to do. And we're going to get into that conversation in a moment with my panel, who I'll introduce in a sec. Just to say welcome to all of you in the room and welcome to those who are joining online as well. We've got a whole host of people who are dialing in too. Just the kind of usual housekeeping arrangement announcements. So I've put my phone on silent, so we appreciate if you could all put your phones on silent. We're not expecting any fire alarms. If there is one, then the fire escape is at the back of the room, so it's quite easy. So if the fire alarm does go off, do leave, it's not a drill. Cool. So the way we're going to the format we're going to follow today is it's a bit of a Q&A, but we're going to make it a conversation. So after some intros, we're just going to have some questions with the panel. Then we've had some questions being sent in by people who've registered, and then we'll also take some questions from people in the room. And the whole thing should take about an hour. So we look forward to a lively discussion. So look, first of all, I'm going to just ask the panel to introduce themselves rather than explain their bios myself. So we've got Lisa Sewell, Gordon Cullum, and Ishika Mukherjee. And if I just ask you to say maybe who you are and what your background is, what your role, kind of a couple of minutes each, no more than that. Don't need a full CV, but it'd be great. After you, Lisa.
Good morning, everyone. Thank you for having me on this panel this morning. My name's Lisa Sewell. So I have two roles. I'm Director of Data and Informatics for the North Eastern Yorkshire Genomics Service, but I'm also Programme Director for the Great North Care Record, which is a successful initiative here in the North East and North Cumbria, and really pleased to be part of the conversation this morning.
Thank you. I'm Gordon Cullum. I also have two roles, but not quite like that. I'm a director of a consultancy in Leeds called Axiologic, and we provide digital transformation and digital leadership for our clients, many of whom are in the healthcare sector. I'm currently working with a client. I have been working for quite a long time, probably on and off over the last 20 years, actually, in NHS England, as it is now. I need to get that one right. Working on an architect in the screening programme.
I'm Ishika Mukherjee. I am a user researcher here at Opencast. My background is in user research and service design, so I sort of bring that user-centered design into innovation and especially digital innovation. I've been with Opencast 2 years now. I've done a lot of projects in healthcare, which is why I'm here, and very honored to be sharing the panel with you guys.
Cool. Great stuff. Thank you very much. So look, I think we're going to try and keep this fairly positive and optimistic, because I think it's very easy to kind of drag yourself down into the mire of, oh, isn't this really hard to scale stuff and do stuff in the NHS? But I know we've all got examples of how it can happen. So I kind of want to focus a bit on actually how things have been brought to life. So let's get all the negativity over with at the beginning and talk for maybe the first bit about just some of the challenges. So we all kind of know that healthcare, rolling out innovation and scaling it in healthcare is difficult. So maybe if we just pick up one or two of the challenges, and I kind of speak from experience. We 13 years ago founded a business called eConsult, which does digital triage in both primary care and now in hospitals. And it's taken us a long time to scale that innovation within the NHS. So, but it's certainly possible. It just takes a long time. But rather than me tell you about all the challenges we've faced, it'd be great just to think about kind of why is this difficult in healthcare? And I won't always do this, Lisa, but I am going to pick you first.
So why is digital innovation challenging within the NHS? So I think the first thing that we need to be really clear on is the purpose. What is the problem that we're trying to solve? Why are we innovating? I think very often there can be a new idea that's seen as the answer to a particular problem that we haven't even described. I would also say that technology can't do it on its own. So what we need to really consider at the start of any innovation is what is the purpose, what are we trying to solve, and ensure that we've got strong clinical and operational commitment before we even begin to mobilise. It is possible, but without that common purpose and without trust, it can be really, really challenging. The other thing just really to call out is the infrastructure that we have across the NHS to support our technology stack. I know we'll talk a little bit more about the AI opportunity as we get through the conversation, but we need to invest in core infrastructure and interoperability to really release the benefits that innovation can bring.
Yeah, very good point. Gordon.
I think the interoperability is a thread I'll pull on there. So I often end up working with people who are coming new into some of my teams, often new to the healthcare sector. And it's worth recognising that healthcare is one of the world's oldest professions. It's organically developed for thousands of years, and there's a huge amount of complexity in the environment, and that's reflected a lot in a lot of the standards that are in place. So we can't shy away from the fact that not just the technology, but some of the things you have to consider when thinking about data interchange standards they're a huge barrier to entry. So once you've identified what that problem might be, why it has value, and you need to get into I'm going to execute this innovation now, and you start pulling apart things, you start looking at things like HL7 and FHIR and how to discover how you can discover which trust to send a message to and things like that. You suddenly realise it is incredibly complicated. Some of that is justifiable, some of that is just, that sounds awful, it's baggage that we've accumulated over 30, 40 years, but it is nevertheless there. Yeah. And I think that makes, there's a fear and a reticence for some people to engage in that. So they've had the great idea, they'll lean in and go, I can't do that. I don't really know how to do that. So maybe sometimes we ought to, I'll jump into the solution now, that's what I do, but dissociate the idea from the execution.
Yeah.
Maybe that's how we get around that to a degree, and there might be examples of that we can talk about later.
Yeah, absolutely. Ishka, challenges.
I think from my perspective, one of the bigger challenges that I have seen is embedding user-centered design and embedding it really, really early on. So at maybe a policy level where we are discussing what the problem is and bringing in the solutions to truly understand what it is that our users want. And in a space like healthcare, users are so many because it's not just the end users. There's, of course, the end users, the patient, the carer, but then there's also the clinicians, as you pointed out, there's the case managers, there's the admin staff, and of course the business. And it's such an interesting and really exciting time for technology, AI, we'll talk about all of that. But how do we really leverage that to support human beings be human beings? And how do we make that better, I guess?
Yeah. Yeah, cool. Excellent. Yes, no, indeed. And as I say, I'm not going to linger too long on the challenges. So I'd rather get onto some kind of good examples of where those challenges have been overcome and we found a way through. So perhaps it would be good, and Gordon, I'll start with you this time first, just to give a brief example of a digital innovation from your area of work, something that you were involved in, and why it worked. Like what was different that actually made this work?
Okay, why it worked. That narrows the field down to what sort of worked.
Okay, sorry.
And this is apropos nothing. I'm not going to pick an NHS example. We did a piece of work with a private healthcare client some time ago. Only just over 18 months ago, actually. They had some big major contracts with the NHS, and they were looking at understanding how they might scale some of their core operations to be able to support these large contracts without it becoming a linear problem, like build another call centre, build another integration to the PAS, or even buy another PAS, actually. So speaking to the point you were just raising about patients aren't your only users. You've got all kinds of users in that space. We did almost a classical piece of consultancy, which was an analysis of all the business flows, where all the common points were, where we could pull out commonalities, where we can design a piece of infrastructure around that commonality. The lesson I'm going to pull on here is sometimes the smallest things have the biggest impact. Mm-hmm. We found that there was I generally can't remember what the app was, but there was an app in there somewhere that fulfilled part of the appointment rebooking flow. The ability for someone to say that appointment doesn't work for me, I'd like to rebook it, please. That is hard in healthcare, believe it or not. Many of you probably do believe that's really hard. If you look at things about screening and vaccinations, for a very recent example, in this particular case, it was for community diagnostic screening, I think. The innovation was just a bit of user research and a bit of reflowing of the app. That was it. It was probably in total, in terms of effort, from identifying the problem, analysing, doing a bit of user research to analyse how the flow might be reimagined, and then execution, 2-3 weeks work, something like that, for a couple of people. And that probably had a more profound impact on the ability of the organisation to support the contract that they were trying to do, and therefore the onward effect on health of the population that screening would impart, than, well, at least bang for buck from a low-hanging fruit point of view, than some of the big things we were trying to do. So I guess the lesson is, don't always look for the big problems. Sometimes the smaller things you can bite off much quicker and get a much quicker return to value. That's probably a principle of shift left, I guess.
No, absolutely. Ishika, what do you give maybe an example of digital innovation like worked and
I can talk through a project that we did with Opencast with DWP Health Transformation Area. It was a really interesting project because it's very future facing. So it was about their 2029 target operating model, and we were looking at how we can make the entire system of people trying to claim health related benefits better. We all know there's a lot of scope for improvement. DWP know that. So they wanted to embed UCD very early on in the process. And we ended up doing that. We ended up having a transformed case management system. And the thing that worked was UCD and user research, and really understanding. I mean, we know the problem, so we know the appeals, we know why users appeal. But it was sitting with case managers, seeing how they process every application, seeing and them thinking out loud, and us understanding sort of biases and things like that. And we all have biases, right? And how we then use data to get ahead of that curve almost. And it was that helped us then enable that kind of transformation. So it wasn't just digitizing something or adding a new piece of technology. It was really reframing how we're looking at the problem and reframing the approach that we're taking to the solution.
Cool. Great. Lisa.
So I'm going to talk about the Great North Care Record because it is something that I'm immensely proud of that we've achieved as a region. So if I think about when we started in our region, looking at how we give a holistic presentation to support direct care in health and social care, it probably started in about 2012 as an ambition. In sort of 5 years ago, we obtained some funding via the Healthy Cities programme to pump prime and develop the investment that we needed to build the solution. But why did it work? It worked because it was the right thing to do. We didn't strive for perfection, to the complexity in terms of interoperability, data maturity in individual organisations. We consulted with the public, about, is this the right thing to do? And it's something that as a region, we are probably leading with One London. Not that we're competitive in the Northeast. No. Come on, Newcastle. But I think it is about purpose, it's about commitment, it's about will. I know we'll talk about information governance and cyber a little bit later during the conversation. But if you get a common ambition and you have the right level of influence in all the individual organisations, the rest will flow. I think that's all.
That's very good. Cool. Thank you. So look, obviously we've all been waiting some time for the NHS plan, and we're still waiting for the NHS plan. But what we did hear last week was that there's going to be a big investment in technology and increasing kind of the technology budget by at least 50%, with about the whole analog to digital shift and about 10 billion flowing in. So thinking kind of in the context of what we're talking about, what do you think this boost means for innovation in practice? So how could it, how could this help?
Yeah,
I'll leave it open.
So, okay, I'll go with the gut reaction first of all.
Go on.
There's nothing in there about how. And I think that's probably the nub of the question, really, isn't it?
Yeah.
Because the temptation is, oh, there's a big pot of money there. Here's a bunch of legacy applications and legacy tech. Let's pay back some of that debt. Or it might be framed that way, but we've still got systems running on months out there. Yeah, I can spot the engineers in the room. So that might be, they could easily burn through that. And I think anyone could spin updating legacy tech stacks as being innovation. So there's probably, I'll say this as somebody who's been in the industry for a bit too long, it needs some new blood, I think. How do we attract people into healthcare and not make them fearful of standards and governance and compliance and DPIA and cyber? So using some of that funding. So is the how, could that be portioned somehow maybe? And could there be a campaign to attract people into the industry with new skills? I'm not even necessarily saying from adjacent sectors. I genuinely possibly mean brand new thinking. So the generation probably behind me thinks very differently about coming up problems. So that's my gut reaction to it, I think, which is I don't see the how, and here's what I think the problem might be.
So exactly. We do need the detail that sits behind the pledge.
And I think just building on that, it's what type of money is it as well?
Well, indeed.
Is it capital? Is it revenue? And we need to be really clear that there needs to be innovation from sort of a top-down perspective. But to your point, in terms of attracting new talent, trying things differently, how do we allocate to the front line to make sure that we're doing things that are going to be impactful? So I think that's going to be really important. And evidencing the impact of that investment at a system level and a local level, I think is really important.
Yeah. And do you think we've been good at that in the past?
No.
Do you mind if I ask something to that as well? Because I think one of the things that healthcare is very exposed to, of course, is the sort of Daily Mail effect and the publicity of things that don't work so well. And if you're going to, one of the facets of innovation is you've got to accept that not everything's going to work. You have to be able to fail and be okay with it. Failure is a good thing. Not even fail fast or accept failure. It's embrace failure. Embrace the fact that if you're going to run 4 experiments, 2 of them aren't going to work, or 3 or 1, depending on the industry you're in and probably trying to solve. And I don't think healthcare is very good at that because it's such a political hot potato, especially the big ones that spend lots of money. I'm not saying play fast and loose with public funds, by the way, but I think systematically, as UK PLC, we need to be okay with the idea that not everything works.
And I think, can I just build on that? I think it's really an important point in terms of we don't learn the lessons. So whether it's failing fast or whether it's permission to fail and learn, how do we share those learnings so that we don't repeat those in a cycle? Sorry.
No,
that's okay because you were nodding a lot.
Because before this, Lisa and I were having this conversation, and I was telling her that I want to say fail faster, but I'm afraid of saying it. But that's the Daily Mail effect, right? Like we're afraid to say fail faster. But I think that is some of what changing the culture towards something more agile can do. And I think that's a massive opportunity in this situation where we can change it and we can run very quick tests, iterate, speak to the public, see what they're saying, see how clinicians are practicing, and iterate very quickly. So essentially fail faster.
Yeah, absolutely. So hopefully that will that will generate a bit of kind of optimism as we move forward. I think if we kind of go down maybe into some detail on how and why we unlock innovation in some specific areas, and thinking maybe first about kind of data innovation, because I know this was a hot topic both for for the public and for the clinicians within the NHS. So data is sensitive. There's cybersecurity considerations, but what are the kind of the balance of challenge and opportunities within the kind of whole data opportunity? And probably, Lisa, I will pick up with you first.
So I think it's really interesting because there's a perception that information governance and cybersecurity may be a barrier when we think about innovation. I think as an NHS, as suppliers, as supporters of the NHS, we need to change that thinking and really embrace them very early on in the process. Again, in the North East and North Cumbria, we've got a really strong sign group where all the individual DPOs and IG professionals come together. and they're probably one of the key facilitators in our ambitions around data.
Yeah.
And from a cyber perspective, I think there are some really good frameworks now to support us in healthcare, making sure that our boundaries are secure. And the lessons that we've learned from our retail counterparts more recently, I think has really strengthened the commitment within all organisations to invest in cyber. So in very simple terms, talk to the governance professionals as early as possible with an idea. They will find a way, if it's appropriate, to use that data for the benefit of innovation and research. The other thing that I would add is just really around the opportunity that the secure data environment offers within each of the regions. I know nationally and politically, there's lots of conversations around, where does this all fit together? And I'm sure it'll become clearer in the next couple of months. But the STE gives us an opportunity to do something that researchers have done since the beginning of time, in terms of it allows them to go to a safe space, extract the information they need in a safe environment, and use that for the greater good, whether it be service improvement or research and innovation. And I know certainly in our region, we've got a Section 251, which means that we can use that information appropriately for the benefit of the population.
Cool. All right.
Also?
So I can speak to this through sort of the other side of it, so the user side of it, because health data is very sensitive, and data in itself has become a little bit of a scary word, I think. Earlier on in my career, one of the projects that I'd worked on was with a diabetes startup, and that was specifically for adolescents and young adults who have type 1 diabetes, and for them to be able to manage that using sort of their blood glucose monitor data. And that was sort of the amalgamation of data and health data and a child's health data. So it was a very sensitive area. What we found really helpful in that situation was empowering the children and their parents with what is the data that we're collecting, and where is this data going, and exactly why we need it and how we're using it in very plain, simple language, so that you sort of make it less scary, so people are more open to us then. I don't want to say using the data, but essentially using the data to build something that is for them. So yeah,
absolutely. Gordon, anything to add?
Yeah, I think I mentioned earlier, some of the barriers to entry might be perception. So, and it's not that perception is in itself a bad thing. It manifests ultimately over time in policy and law and so on. So when you think about the barriers to actually developing systems, I've worked with so many engineers, got to get the DPIA done. And then, that's going to be a stumbling block. So shift left by all means, but they are difficult things process to go through. And then you start thinking, well, the admin overhead, having to go through that each and every time you want to do just one little thing that's a little bit different with that data set. And how do we think more strategically about creating more encompassing data sets that we can have a more general governance rule set around? But then where's the line then? Because there's the whole point of having a DPIA specificity, and there's a natural aversion because health data is scary for many reasons. It's very personal. If you use it wrong, it can be catastrophic results. There's lots of reasons why it genuinely is like scary data. It's not made up. So I think that's part of it. And as a result of that, not only do things like governance and assurance then, so IG, cyber and so on, feel to some people like they are barriers. So there's the cultural thing we can do in digital delivery pipeline to try and shift that left and try and see assurance as an enabler rather than a blocker. They're all great. But then there's the actual implementation of that data is in, as I said earlier, a complicated format. It is to people who aren't experienced already with the kind of structures that are installed and how it's stored, impenetrable. Being able to appreciate that there's a set of dictionaries and taxonomies for coding standards, and are you using ICD-10 or are you using SNOMED, and which interchange standard have we used to actually get this data into that IHE format? Have we used FIRE on the Y or HL7 on the Y? All of those things, none of these things are trivial. The standards manuals for some of these things are huge.
Yeah.
So I sort of reiterate that point a little bit, really, which is that's why that's hard. And what it also means then is you're probably building squads of people to look at these innovative problems or solutions, sorry, out of experienced people, and they're expensive.
Yeah.
So that's the other half of it, and you end up with there's a natural two-side expenditure. It's a long, complicated process, and you're using experienced, expensive people.
Yeah. Yeah. Cool. I want to talk a bit about user-centered design, because I know that's a big focus, having worked with Opencast for a number of years now, and I really kind of welcome that approach, because I think, for too long, certainly even when we were selling our tech into the NHS, everyone just thinks about the kind of technology, and back to your point about what's the actual problem we're trying to solve here, don't just buy tech. So I think if we can just focus a little on that now, and kind of thinking about unlocking innovation. So how can user-centered design help deliver impactful innovation? And Ishika, I'm going to start with you here, but if you've got any more examples of kind of where user-centered design actually, the value of that service design helps kind of deliver a good outcome.
That's a really good question. I'll use an example to talk about this. I worked in a large digital transformation project for AXA Health, so private health. And what they wanted to do essentially was that they just wanted people who use AXA to be more proactive with their health. We're seeing that shift a lot more now within government as well, to try and make things more preventative and people to be more proactive about their health. And so we did a lot of user research to try and understand what it is that motivates people and drives people to take action on their health, and equally what motivates them to not take action on their health. And it was a 9-month discovery where we mapped a lot of emotional journeys. We spoke with clinicians. We figured out how to sort of take the clinical side of things and help people really understand what it is that they are trying to achieve, and worked and built that product basically from the inside out. So starting with people's lives and meeting people where they are, that was a big thing, instead of just giving them a piece of tech and saying, okay, now here you go, use this. Really building it into the service. And that's another key thing that service design does, which is sort of things are fragmented, and there are so many different departments within AXA, for instance, but I think in most healthcare or most spaces where there are so many different departments trying to do their very specific thing. And service design has the ability to like bring all of that together. So we design something that is cohesive and leverage all that we understand from all of these different areas. That answer.
Yeah, absolutely. Very good. Lisa, Gordon, any kind of user-centered design?
So just another example of that sort of at a system level is we've worked really closely with the LMNS, so the local maternity network, and they spent probably about 18 months considering and thinking, and again, we were chatting about this earlier, around how could we create impact for the population that we serve in terms of prenatal care. That probably took about 18 months. I would urge you to go and have a look at the research, and I'll share that after the event.
Please do.
Excuse me. But as a result of that, we've then built a solution that allows any mum in the North East and North Cumbria access to their information regardless of where they're receiving their care. They also have the opportunity, in terms of from a clinical and care provider perspective, to see that information, and it's appropriate. Yes, there is still work to do, but we as the technologists listened to what the people and the network said was going to make a difference within care. So at a very high level, I think we should start thinking about those principles at the fore of most things.
Cool.
Yeah, I'm going to stretch the word innovation ever so slightly for this.
Please do.
So I'm going to think less about the outcome of the product that might be innovative, or a service might be innovative, and think more about the process that we went through and how we might have looked at something from a slightly askance angle. And I'll speak the work I'm currently doing. So digital screening is a a set of teams within the digital prevention services portfolio within NHS England. Preventative services is all about developing digital solutions to enable uptake of prevention services, very obviously, which therefore reduce the burden on acute services. That's the mission statement at DPSP level. Digital screening has a number of missions around the fact there's 12, 13, depending on how you count them, legacy screening programs running in the UK. Yeah. Programs meaning the breast screening program, the cervical screening program, the bowel screening program, and they're all running on their own business processes, their own technology, often procured from third-party vendors. Not that there's anything wrong with that particularly, but they have their own legacy challenges and their own ways of working. So if you've read the Professor Sir Mike Richards report from a few years ago, it posited that they're actually doing very similar things, these programs. Ultimately, when you express it, they're actually doing a set of staged gates that you can break down in a service design way that looks quite common. But it isn't actually articulated what that is in the report. It just posits that that's true, and therefore you could look at this in a common way, and therefore you could build a set of services that could be a future state. So about 9 months ago, we took on a piece of work to build out what we call a service blueprint. And the slightly different approach that I think that we were taking, other people may have done it, but to us it was innovation within our teams, was service designers, business architects and technical architects working in the same room together at the same time. Now that might sound like an obvious thing to do, but whilst we were planning out the pathway of plan a campaign, engage with participants, communicate with participants and book appointments, do the screening thing, the mammogram or whatever, record the outcome, and unfortunately type in, but should be across the top, monitoring the whole pathway. You can break that down into a set of services that have to exist within each of those things to be true. You have to be able to create appointments. You have to be able to book appointments. You have to be able to communicate with patients in a common standardized tone and fashion. You might even think about personalizing that communication and things like that. That might be innovation in NHS. But the approach of doing all that means actually we were using business architecture language and business architecture concepts to design a taxonomy to describe the service design. I know I'm using very architectural terms here, but the approach itself had never been tried before. Oh, well, normally service designers go off and do a bit of service design work, and then we architects look at it and go, oh, right, we'll need a database and we'll need a CRM and we'll need an integration engine. Yeah. We weren't doing that. We were actually all in the same room planning it out together. Now, whether or not off the back of that we build a canonical screening platform that can be reused or not, probably, well, that would be great. But even if that isn't true, the fact that we've got all those people talking the same language, having gone through that process, and it is starting to get embedded in the way that the digital screening teams talk to the individual legacy programs about, you know, when we say cohort management, do you understand what we mean? Oh, yeah, we know what that means. Yeah. Cool. So those things I think were new for us. Yeah.
Absolutely. Great. Thank you. So look, I'm now going to move on slightly to take some questions, not from the audience yet, but some people were asked to do homework. So well done to those who did their homework and sent in questions before the panel. So we have some of those questions. So I'm going to just pick up a couple on those. And the first one I'm going to pick up is a fairly obvious one, because you can't do anything in technology now without talking about AI. So we will kind of bite this off now and talk about AI. And I know I take the point earlier that actually, you know, it's all very well sometimes thinking about kind of AI and the future, when actually in some circumstances we haven't really got the basics right. But I think there are opportunities to use AI. A little plug for a case study that Opencast has just done. We've done a bit of work to launch an ambient scribe with Opencast, and actually that did use a lot of user-centered design to really talk to users about how are we going to make this a scribe that actually is useful for GPs and nurses working in primary care. So for those in the room, there's copies of that on your chairs. But so I think the kind of broad question which did get sent in was, how best can AI be harnessed to deliver positive innovation for healthcare? So maybe, you know, kind of, you've got a nice broad question there, so you can, you know, do what you like with that one.
So notwithstanding the challenges of infrastructure, interoperability, again, just to really describe a really positive use case that we developed in Newcastle. So in 2022, we started working with one of our partner organisations and our EPR supplier to look at how could we use AI in its broadest sense to improve the early identification of VTE, so thrombosis, which is a challenge across secondary care. And more importantly, how could we use that intelligence to reduce hospital-acquired thrombosis? So we started in 2022. As everybody understands, it takes a while for the algorithm to be developed. It took a lot to get through exactly what I described earlier in terms of making sure that we had appropriate governance around the data, around cyber perspective. Integrating with a large US healthcare provider is never, software provider is never easy. So that shouldn't be underestimated. But in terms of the clinical expertise that we had to help train that algorithm, I'm delighted to say probably in August 24, we achieved something that was allowing nursing professionals to use their skills to identify areas of need for greater care, but we'd created from the radiology reports essentially a work list that took the heavy lifting out of that manual interpretation that was taking a significant number of hours. And that work has been published as well. So again, I don't know, a bit like a broken record, making sure that you've got what is it you're trying to achieve.
Yeah.
Give yourself time to do it safely, securely, and make sure it has benefit for the patient and the people providing care. And all credit to Catherine Musgrove and Chris Plummer, who helped develop that model. But again, I can share that detail. So it can work, but come back to what is your problem?
Yeah, absolutely. Yeah.
I think that's interesting because my temptation here was to steer away from the almost Hollywood view of AI in healthcare, which is augmented decision making or even automated decision making for healthcare outcomes.
Yeah.
And go right to the left hand side and say, well, actually, we often overlook the use of AI in the processes for change.
Yeah.
So AI actually in the development of systems, so in a design, analysis, and development phases, and that's relatively common now.
Yeah.
Whether we like it or not, developers probably are using Copilot to augment them with code or some other tool. And we're increasingly using generative tools in the design phase to create artifacts that help us sell the message we're trying to get across in articulating a particular viewpoint of a design.
Yeah.
And that's not to be overlooked, because if you can shave time off or get a message across that might have gone back around the loop or back around the governance loop 4, 5, 6 times, that cuts down your time to market on that solution.
All good. Yeah.
But actually, the more you talked, Lisa, the more I thought there about the public would naturally be reticent if we started talking about things that were either taking agency away from a human clinician. But where we can aid in administrative workflows or clerical workflows, that's less of a hot topic. And actually, some of those are logistical problems, and machine learning is ripe for those kinds of things, right?
Yeah.
And again, there can be massive efficiency savings there. And if you make efficiency savings, you can reinvest the money elsewhere, which means you can then improve health outcomes. So I think I would, at the moment, given things like where we are in the climate, where we are on the sort of public perception of AI, and I won't say scaremongering because there are genuine fears out there. I would say focus on the things that are likely to be less contentious, either where it's already adopted or where it's less likely to scare people who aren't as aware of the limitations and or constraints might put around these tools.
Yep.
Really, really interesting examples. I think one of the things that in UCD and the sort of cross-section of UCD and AI, that's one of the things that we think about a lot is when it comes to AI, the data that we're using to train the models, how correct is that data? And I think UCD is really impactful in being able to test that very early on and really make a difference there. So going back to the type 1 diabetes app, for example, that we were talking about, one of the first prototypes of that app was built on sort of a lot of proxy data that was gathered from older cases. And it doesn't use the data, or how do I explain this? It's not exactly what the child is going through or the young adult is going through. For example, it uses other parts of data, which is equally important, but then it is also important that we really look at what is the problem that we're trying to solve, and not just use data for the sake of using data almost. And so if we look at the whole problem and look at the deeper, meaningful problem that we're trying to solve, we then get to the crux of what is the most important data here.
Yeah.
And then channel our energy towards getting that data and then building from that space.
Yeah.
Yeah.
Cool. Brilliant. Good. Thank you. I'm just going to take kind of a slightly different question from the floor, but actually it's an area we touched on earlier. I want to go into a bit more detail. So when thinking about planning for innovation, how do you balance the needs of the different people in this equation? So the needs of the patients versus the needs of the clinician versus the needs of the organization. Which comes first? Now, or how do you balance that? I think that's because it's a key one.
That is a tough one. I was asked a very similar question earlier. Well, not quite similar. I was asked how leadership forms a view on how innovation could or could not be successful. And I think that's sort of my answer to that, because some group of people somewhere needs to be the arbiter of what's valuable to us at the moment as a group of people trying to articulate a change. Is it efficiency? Is it driving a particular health outcome that is first and foremost in the public mind, or it's actually causing an effect on an industry or the healthcare service itself? Is it a winter pressure problem, for example? So I think I would probably be tempted to say this is a leadership question, which is who's actually setting the tone for that, and where are they getting that from? And is that flowing through? So it's a leadership and communication, actually, it's both. So is there traceability for the things that we care about as change professionals back to the core agenda, the core mission, if you like, and is that articulated well? And the flip side of that is everyone bought in?
Yeah.
You can have that written down in black and white as a traceability matrix for all I care, but if people don't emotionally feel it, what's the point?
Yeah.
You've got to have a bunch of individuals who are both able to execute on that and are invested in it in some way. I used to have a favourite phrase when I was building team, which is a team that knows why it's there will always outperform a team that knows what it has to do. So I think that's probably my sort of pithy answer to it, which might seem a little bit like a LinkedIn meme, but it's genuinely true.
Yeah.
I think someone's got to hold that chalice somewhere.
Yeah. Good. Lisa.
And really, if you've got it right, I absolutely agree with what you said. Who holds that? Who makes that decision? How do we react to the mandated need against the cost pressure, et cetera, et cetera? But if we are prioritizing pieces of work that bring value, the patient and the citizen should be at the fore.
Yeah.
As part of the user design, we should be making things better, easier, safer for our clinical colleagues. And by, the outcome is efficiency for the organisation and the wider community. And again, that's a bit of a textbook answer, but the patient and the population should always be at the start of that prioritisation and decision-making process.
Yeah.
For me, that's what drives me.
I think this is where service design comes in.
Yeah.
Really, really really integral part of being able to do this, I think, is to co-create the solutions, the products, the services with the patients, with the users, but then also equally with the clinicians and whoever else is involved in this. And I think that is the point of service design, to give everyone that holistic view of it's not just the patients and it's not just the business and it's not because there's the tech of the people who are actually building it, so the developers, and there are so many different voices. And I think it's the job of the service designer to bring all of that together so that we build something that is cohesive and comprehensive.
Yeah. Cool. Good. Thank you. I'm gonna in a moment just start to take questions from the audience. So this is your moment to have a little think. If you've got a question, prepare yourself, and we've got a roving mic, so we'll do that in a sec. But just while you're kind of thinking about that, I mean, I just wanted to pick up on that point about kind of clinicians versus patients versus the organisation, because actually, and we spoke about it exactly this time last year in this very room. when think about what we do, which is we do triage in general practice, and it's really interesting because we built that both with patients in mind to make access better for patients and for clinicians to try and make their lives more efficient. And then what has happened over time is the system has evolved mainly because it's become very competitive, and competitive brought in this ability to turn these systems off. And so what that means actually is if you're a patient now and you go and try and do an online consultation, often those systems are switched off, which is like the kind of digital equivalent of, I'm sorry, we've got no appointments, please ring back tomorrow. And we've kind of inadvertently kind of just perpetuated the old model of access digitally. And so you kind of, you know, it's a really hard balance, I think, to kind of balance the clinician, what the clinicians can do versus the patient. And anyway, cool. So thank you very much. We've got a mic. Has anyone got any questions for this panel in the room? And don't worry if you don't, because I've got lots more questions I can ask. But if anyone has got any questions they'd like to ask, now's your opportunity.
Fannick Smith from Floki Health. If the byproduct of what you do saves time,
yeah,
and that's time for clinicians,
yes,
how do you relate that specifically to the finance director who makes a decision? Because that is the significant challenge. You can improve the service.
yeah,
You can create a value for both the patient, reduce stress. And at the end of the day, it's humanizing it and making it a value that really gets across the line. And I think the disparity, and the question I have is, how do you bridge that disparity between the finance director making a value and revenue, which can be spent to save time when you've still got that overhead of time?
Yeah, it's very true. Thanks, Fennick. Who'd like to pick that one up first? It's not an easy one.
Well, I mean,
It's a challenge.
yeah. I need some time to think about that, if I'm brutally honest. I think it's not an area of my expertise. It's the first thing I'll say about this. So I'll probably give a more of an academic viewpoint, whether this could be translated or not. But clinicians' time can be translated ultimately into funds, right? It can be translated into, because it's not just a T&M thing. It's not just about if you saved, I don't know, 10,000 hours, that equates to X thousand pounds. It's not that simple, because there's the scheduling effects, there's the fragmentation effect, there might even be things like the sickness effects, stuff like that. It's actually I'd imagine, if you were to model that out from a pure human impact of releasing those hours, quite a large accretive effect you could actually try and model. That might be the mathematicians and accountants answer. What I'd like to say is, why would you want to? Surely the financial director, the finance director, isn't the only person calling the shots, because actually the value being released is the clinician's time, not the value of that time in terms of pounds and pence, but the value of that time to the patient, as in people's lives, people's health outcomes. And the reason I say that, probably with the passion that I just said it, is I'm not a finance director, but when we used to do, over the years as a consultancy working in the healthcare service, we've done case studies over the years, and sometimes we consciously choose not to talk about the money we saved. We deliberately talk about returning our clinicians, because to us, that is the value. You know, I can feel myself getting emotional about it, but that's sort of, I'd almost refute the question and say, why would I want to? And if the answer is the FD is the ultimate call in the shots, well, someone needs to tackle that then, because maybe that's not me. Maybe that's my slightly spicy answer, but yeah. I'm getting scared.
Ignore the FD.
It is a real challenge, and hi, Fennick. It has to be more than just the money. It has to be the value that's brought. And I think you've articulated that really well. We were talking a little bit earlier about how do you quantify value in these sorts of initiatives? And I think it's an area that collectively we need to mature in.
Yeah,
That's definitely true.
agreed.
I think to echo what you guys have said, while I've not had this very specific situation of dealing with finance directors, what we have had is challenging stakeholders who don't want to think about the users and want to and they have larger problems, they have larger goals to meet. The thing that we've been able to do is bring them along on this journey, help them meet the users, listen to what the users are saying, and it does build empathy. And I think that with UCD, building that empathy is a step towards changing their mind, I suppose.
It's the core really got to bring the users on.
Exactly. Yeah.
Both the excitement and the investment and time.
Yeah, exactly.
Yeah.
But ultimately the decision is, does it get both? Does it not?
Yeah.
Yeah.
That is the challenge.
That's absolutely right. And I do think probably that the voice of the finance director in the last 2 to 3 years particularly has almost got louder as we have been in a difficult kind of environment for funding. So that's just a fact. They've kind of, you know, it's been more difficult. Any other questions from the floor? Yeah.
Rachel McElroy from Axiologic. So without compromising yourself in any way, if you had one wish for making innovation happen in healthcare, what would it be?
Only one.
Yes.
So I think just building on everything that we've talked about today, that we had the capacity, the capability, the workforce to truly mobilise.
Again, something we said earlier, and I'll try and be less than my normal, very verbose way, the psychological safety to allow some failure. I think that's a really big thing. And I will be verbose. And I don't think that's just on very senior leadership, so ministerial and sort of directors and so on. I think that's also incumbent on the execution. If we can make it, if we can use tools, techniques, modern ways of thinking to make parcel size delivery cheaper and easier, it'd be easier for the environment of safety to exist, because the money becomes hopefully less of a question, because you can fail fast earlier in the money cycle, not just the time cycle. So it's not just a leadership; it's incumbent on all of us to create that environment of safety. So that's my wish, because I do find that a struggle.
Yeah, I think on a similar vein, I would basically say the same thing in a different font, which is that embedding UCD earlier on in the process, so that when we are at the level of thinking about policy, we are at that time thinking about the users, and building UCD sort of into the process, so that you do have that psychological safety then to test, iterate, fail faster, move on, try something else.
Yeah, cool. Good. I think we've probably got time for one more question, if there is any from the audience. Yeah, go on. Great. Hello.
Hi, hello, everyone. My name is Kenyode. So, very great conversation. So, I'm an artificial intelligence student, just finished, and venturing, or rather, I'm playing with the idea of healthcare in my mind, but also thinking about the ethics and responsibility, AI, and all of those things that surround transparency with the use of this kind of systems. So, because I'm very passionate about health, I did my project and my thesis around doing my thesis around something that is very related to health, and understanding how these systems make, for example, certain decisions, and how it can also impact humans. So this is my question, which is centered around UCD, policy, ethics, and all of that stuff. So in designing, for example, healthcare tools using AI, especially those involved in decision making, just like what you were describing. Now, how do we balance this AI intelligence with now user-centered trust? Because of course there's UCD, and then there's how we need to trust the users. If you know, we need to buy in the users' trust as well. So how do we, particularly when these patients or clinicians, who might interpret the AI's reason as human-like, because that's where it is. Yeah, we're at that point already. So for instance, like I said in my research, I explored how different prompting methods reveal the moral and cognitive leanings of AI models. Now, should we be building in transparency and not just what the decision, not just the decisions the AI make, like, and how it arrives at them, even if it reveals its limitations? Because when we're talking about transparency, most times we're thinking about, okay, how did it arrive at this? Because we expect it to be good, but I won't say nobody, but the conversations is not leading towards, okay, even when when he arrives at decisions that are quote and unquote not good, which exposes limitations, how did the AI arrive at that? So that's pretty much my question. How do we handle that?
Good question.
Really good question.
Yeah.
We've got an hour to, no, I'm joking. It's a really good topic to unpick, but yeah, any thoughts from the panel? Stunned them.
Well, I mean,
It's a really deep question.
yeah, you've encoded
Yeah.
almost the reason why we can't answer that into the question. The transparency of a non-deterministic systems for answering questions like that it could be exposed, but it's incredibly complicated and difficult to consume. If you tried to explain to somebody how an LLM took your question and gave that answer, the description of the transparency of that answer would take you months to consume. It's just too complicated. So the short answer is you probably can't. So if I might paraphrase your question, see if this works, is how do you sell that message to users? Say, why does that matter to you? And is there a different way of building your trust? Maybe that might be a different way of approaching the question, for which I also don't have an answer, by the way. And I wonder if user research exists in this space about, is there any research around how we? I'm asking the question now. Sorry.
It's okay, I'll just.
I think that might be a different way of tackling this.
I think does the research exist? Not as much as there should, I think, is the short answer to that.
Right.
Because yeah, exactly what you were saying, like with things like Gen AI, it is very difficult to get into the very complex logic of why something is a certain way, right? So it's not as easy as here's the transparency of it. I think the thing that I was thinking of was also around, especially in health, because we've seen models that have been piloted in places like the US and parts of India and things where models, because you can't make them completely transparent, you don't know how they're making decisions. So how safe are those decisions, I guess? So at some point, there has to be some amount of a layer of safeguarding around it to protect the end user. So if the AI is saying or diagnosing X thing, there has to be, at certain levels, there has to be human intervention to that. So I guess at the end of how we're designing with AI needs to be that we design with AI, keeping humans do have a role still to play, and we can't just completely just abandon ship for the AI to take over, I guess. Does that make sense?
And I think it's running that clinical validation in parallel to the development of the technology. To give that assurance and confidence and build trust. So it's not something that would be deployed until we were absolutely confident and had that assurance in a transparent way and appropriate level that this will support better care.
Yeah. And I think it's fair to say we're still in the foothills of this.
Absolutely.
So, it's kind of right. We are nearing the end of the session. So while you just have a gather your thoughts, maybe for a kind of closing remark or two, just to kind of sum up. I just want to thank everyone for coming. There will be, for those in the room, and sorry for those not in the room, an opportunity to hang around afterwards and ask the wonderful panel some more questions, if you like, a little less formally. So please do stick around. But I thought we'd just wrap up by just getting some closing thoughts and really thinking kind of about, why you're optimistic about the future in the context of, what we've spoken about really, actually healthcare innovation is happening. I think we are, there's a great opportunity now in the UK to kind of do a lot more. So I'm assuming you are feeling optimistic, but if you are feeling optimistic, maybe a couple of closing thoughts about why, and then we'll wrap up.
To go first,
I don't mind.
So for me, I think the next 3 years present a real opportunity to us as custodians, guardians, and public servants on behalf of the population in terms of what we can do with data, innovation, and digital. I think in the North East, we are absolutely primed to earn our space in the digital data and technology arena. I'm really excited in terms of my new role in the genomics space as to how we start thinking about bringing that information together to truly influence how we care for our population. So in summary, yes, it's going to be challenging. Yes, there's always going to be financial constraints, but I would like to think that in the next 3 years, the North East will be recognised as a real player in this space. And if we don't retain our optimism,
well, let's give up.
yeah,
Exactly.
let's keep going.
Cool. Gordon.
I'm aware that some things I've said earlier may have come across as cynical, but I will temper that with some optimism. The world is in a different place now. People are probably, and I won't make a judgment whether it's good or bad, they're probably a little bit more comfortable with their data being used for purposes beyond its original intent. So secondary uses, we might be used to calling it. So I think that's more accepted now.
Yeah.
So I think we've suddenly got an opportunity. There's more of a cultural opportunity to connect with that and use that. And you'll see that with initiatives like SPR, which is mentioned in the spending review. And then for those who work in NHS, you'll have heard of FDP, and we talked about secure data environment area. These suddenly are able to tap into that consciousness that exists now. So I think that's part of it. The 10 billion that was announced in there is an affirmation that not only is the public recognising this, but the government, our leadership is recognising that this needs investment.
Yes.
If that can be spent wisely, it's a big if that can be spent wisely, and I like your phrase, we are custodians of the future of that, then yeah, I am optimistic. So I don't always come across that cynical and that negative. There are things we can do. I think, yeah, the world is changing. There is a recognition from the population and from above that it needs investment. Those two things together make me optimistic.
Thank you. Ishka.
I think on similar lines, I think this push towards digitization from the top, I think is an incredible opportunity for us to push user-centered design, because user-centered design is sort of central to digital design, right? And push that further up the chain. This is a bit of a plug of like something that we're working on within Opencast as well, and to try and shift where we come in as UCD and shifting that earlier in the process, closer to policy, closer to strategy, so that we are looking at and thinking about that holistic picture and building in inclusivity and accessibility from the very get-go. And I think that is what I'm excited about.
Fantastic. Great. Good. Thank you. I'm aware of time, so I'd just like to wrap up by saying a big thank you to Opencast for organising and hosting this session. Thank you very much. And finally, a big thanks to our panel, Ishka, Gordon, and Lisa. So thank you all very much for coming on.